Hey everyone, Nick Bruns here, Summit Eye Care of Wisconsin. So we think of LASIK and refractive surgery being synonymous. In fact, LASIK is just a subcategory of refractive surgery. In 2024, we have so many different options available, each with their own pros and cons. And one that I really want to talk about today is Evo ICL. So Evo ICL is a phakic IOL. It's not a new concept. We've been trying to do phakic IOLs for a long time, and we've been working decades to try to perfect it. So the latest version, Evo, was introduced in 2022. It comes in a range of about 12 to 14 millimeters, and it sits directly posterior to the iris, anterior of the crystalline lens, nestled in the ciliary sulcus. It's completely invisible to the naked eye, and it provides as good, if not better, visual outcomes compared to traditional refractive surgery or laser vision correction. So it stands for implantable Collamer lens, but think of it like an implantable contact lens. It's indicated for patients 21 to 45 years old with a range of correction or reduction of myopia -3 to -20 with up to 4 diopters of cylinder. There's obvious advantage to the ICL in our high myopes. LASIK or PRK, it's an ablative procedure. We're taking tissue away. So our high myopes, it's a lot of laser energy needed. ICL is an additive procedure. We're just putting a lens in without taking anything away. Even with the advantage of our high myopes, I like to think of ICL even on our low to moderate levels of myopia for a couple reasons. Number one, dry eye tends to not be as big of a problem for these patients. You're really completely avoiding the cornea. You're making a small little temporal incision and putting a lens in, just like cataract surgery, although we're not taking the lens out. So dryness is not as big of a problem. Second, the visual outcomes. Think of where the nodal point is in the human eye. The nodal point is the optical center, and it sits about right at the anterior plane of the crystalline lens. That's right where the ICL sits. So in fact, in the FDA study, 52.3% of patients actually gained lines of vision, which is kind of impressive when you think about it. And then third, something that's really comforting for our patients is that it's completely reversible. If they didn't like the outcome, we could just take it out. LASIK, you can't do that. You can't put toothpaste back into a tube, so you can't undo LASIK. But with this, you could take it out. Now, we've never had to do that in our clinic. Nobody's come back and said, I don't like this, take it out. We've never really had to do that, but we could, and that's comforting. What really is comforting, at least from our point of view, when patients approach cataract age and we start thinking of premium lenses, a lot of these lenses rely on perfect corneal architecture. Well, with ICL, we're not doing anything to the cornea. With LASIK or PRK or even SMILE, you are altering the shape of the cornea, and that does impact the effectiveness or the calculations that go into our premium IOL calculations and ultimately the visual outcome. So it's comforting for us to know that with an ICL, when these patients approach cataract age, we have all the options on the table. So these are just a couple reasons that we like ICL. It is a great option for our low, moderate, and especially our high myopes. Thanks, everyone.